not scientific people, don't panic. Anatomy and physiology means just what is the voice and how does it work? I am pushing the button, but nothing is happening. Thank you. Next slide, and if you can get a working remote, that would be even better. The human voice is extraordinary. In a moment, it can convey the terror of a scream or the beauty of a song. Since it is intrinsic to our lives, you might think that we have understood it for centuries. Not so. We have only really begun to understand the voice since the mid-1970s, and we learn new insights into voice every year. Next slide, please. And still, if you can come up with a working remote, please do. The anatomy of the voice extends far beyond the region between the hyoid or tongue bone and suprasternal notch. Virtually all body systems are involved. Singers understand that, and actors. We physicians sometimes less so, but if you look at any singer, that's John Bon Jovi for those of you in the room with gray hair like mine. You can see that there's a lot more involved, the entire body. Next slide. The larynx itself can be divided for convenience into a skeleton, intrinsic muscles, mucosa, and extrinsic muscles, each of which may be responsible for a voice problem. Next slide. The laryngeal skeleton consists largely of the thyroid cartilage, cricoid cartilage, parotid cartilages, and other structures that are of less immediate importance to us today. Next slide. The larynx, the thyroid, can you put that back where it was? The thyroid, cricoid, and arytenoid cartilages lie in the neck anterior to the spinal column and just below the hyoid bone or tongue bone. The spinal column is bone. There's very little intervening soft tissue as a buffer. When we are born, these cartilages are soft, they're elastic. So if you are struck in the front of the neck, they get pushed back against the bone, but they compress and recover. If you're older, such as I am, they have ossified and they become brittle. So instead of compressing and recovering, they fracture. If you are a surgeon and you are operating on a larynx, for example, for a transgender procedure in which you are trying to raise pitch by bringing the cricoid and thyroid cartilages closer together, that's pretty easy to do on a young person and not so easy to do on an older person where these structures have ossified. Also, when we are born, these structures are located around the third and fourth cervical vertebrae, but they drop to around the sixth and seventh cervical vertebrae as we mature. That lengthening of the vocal tract is part of what we perceive as vocal maturity, vocal aging. Thyroid cartilage in males with a prominence called an Adam's apple or thyroid prominence. Cricoid cartilage, this is anterior or front, posterior or back. If we split the cartilage down the center and look inside, We see thyroid cartilage, but no thyroid cartilage posteriorly. Cricoid cartilage anteriorly and posteriorly. The cricoid cartilage is the only circumferential cartilaginous structure in the airway. Everything else is horseshoe-shaped. We also see the epiglottis, which attaches to the inside of the thyroid cartilage, the trachea, the airway, and this white structure, mislabeled vocal cord. First of all, we dropped the term vocal cord decades ago in favor of vocal fold, which is a more accurate description. The vocal folds don't vibrate like strings. Their behavior is different from that. The German term vocal lips is probably better still. But this is neither the vocal cord nor the vocal fold, yet I ask you to please remember it as a reference point. We will come back to it. These are the laryngeal structures from the side. The hyoid bone with attachments to the larynx. So when singing teachers talk about tongue and its effect on the larynx, that's not just imagery. There really are connections. The thyroid cartilage and cricoid cartilage are connected by the cricothyroid joint, and there also is a pair of cricoarytenoid joints. These are synovial joints. They're made up of the same complex substances that form our knees and elbows, and they are subject to the same afflictions: aging, arthritis, dislocation, infection. Moreover, they are not screw-like joints. They are complex. They move in multiple directions. I will show you more later in this presentation, but they have complexity that we are not very good at restoring if it is damaged. If you look at the larynx from the front, you'll again see the hyoid bone, the thyroid cartilage, and the cricoid cartilage. Now, for those of you who are preparing for multiple choice anatomy tests, laryngeal anatomy is pretty easy. If you can remember thyroid, cricoid, and arytenoid, and the hyoid bone, you pretty much have it. This is a membrane between the thyroid cartilage and hyoid bone, cleverly called the thyrohyoid membrane. This is the cricothyroid membrane. For the most part, anatomists are not terribly creative. So if you know the few basic structures, you can figure out the rest of it pretty easily. Picture in your mind's eye where everything is as you're looking at the front of somebody's neck. Use your X-ray vision to localize the structures. If we remove the thyrohyoid membrane, you can see the leaf-shaped epiglottis attached to the inside of the thyroid cartilage. I'll show you that again in a moment, above the attachment of the vocal fold. The thyroid cartilage, cricothyroid membrane. If we ghost the thyroid cartilage and remove the cricothyroid membrane, we can see the signet-shaped cricoid cartilage, and perched atop it, the two pyramidal-shaped arytenoid cartilages. This cricothyroid space is artificially widened in this illustration. Note that the arytenoids are perched on top of a curved cricoid surface. That's part of what makes the complexity of the cricothyroid joints. I'm not going to spend much time talking about sizes, but I will mention for the physicians in the audience and for any of you who have to undergo surgery anywhere that there are good data on the size of the larynx. In females, the diameter is often as small as a little under 9, and for men, 15 down to 11 millimeters, which is smaller than a 6.5 millimeter tube, which is small for our anesthesiologists, and for men, even an 8mm tube may be as large as or larger than the space. So when we talk about the need for using small tubes in singers and in everybody else, it's just the opposite of what anesthesiologists like. They like the largest airway they can get, but there are documented reasons why that is not always in the best interest of the voice. This is the larynx from an anesthesiologist's eye view. This is anterior or front, posterior or back, right, left, hyoid bone, thyroid cartilage, epiglottis with its attachment, the arytenoid cartilages, and these white structures, which are the same structures that were mislabeled as vocal cord in that earlier slide. They extend from the attachment on the inside of the thyroid cartilage, more or less near the midpoint, and marked by a slightly cribriform area on the outside, to the vocal processes. Now, I'm sure that the physicians in the audience will recall with clarity from our freshman embryology that the vocal process of the arytenoid is of different embryologic origin from the body of the arytenoid. So the junction of the vocal process and the arytenoid cartilage is an embryologic fusion plane, that is to say, a fracture waiting to happen. That is why we never put an instrument underneath the vocal process and lift, for example, to reduce an anterior arytenoid dislocation. We have other techniques for that. The amazing fact is that vocal processes do not get fractured, dislocated, more often than they do. But they do sometimes, and they are a challenge to put back together. Cricoarytenoid joint motion is complex. We used to describe it differently, but really it rotates. Here's an arytenoid, here's a cricoid, here's a cricoarytenoid joint, a pair of them. If you look at those joints, they look like little baby temporomandibular joints or even knee joints. This image was taken, this is a CT scan, during adduction. Adduction means bringing the vocal folds together. Abduction means pulling them apart. And here you see the arytenoids and their angle perched nicely atop the cricoid cartilage. When we breathe in and abduct the vocal folds, not only do the arytenoids move apart from the midline, but their entire attitude and spatial relationship to the other laryngeal structures changes. That is part of the complex engineering design that we are not very good yet at restoring. If you would be good enough to click on this slide and play it, I don't think that I can do that. This again is a CT scan. Courtesy, I'm going to ask you to play it again, so hang in there. Jean Abipal and Albert Castro from years ago. These are the arytenoids. This is the cricoid. Would you play it one more time, please?
Sorry. Try. I think you hit the green button. It should play. Oh. No, not playing it. Sorry.
No. You made it play once. Try and make it play again, or at least play the other one. They did both play out front when we loaded them.
Sorry.
Well, give me the lecture back, please. That was slide 15, if that helps you. And if you would get rid of the next slide display and go back to presentation mode. Thank you. We'll give you one more try to play either of them. Just slide it down to the bottom. Yes.
There we are.
There you go. You see how slight, and try and play the one on the right, please, the same way, the video at the bottom. Do you see how small the actual articulation of the two cartilages is? It's quite amazing that they don't get dislocated more often during intubation. The intrinsic muscles are responsible for adduction, adduction, and longitudinal tension. They are innervated by the recurrent laryngeal nerve and the superior laryngeal nerve. If you can remember that the superior laryngeal nerve innervates the cricothyroid, which is responsible for tension, it helps us raise pitch, then you can get all the others by omission. Everything else helps us protect the airway and incidentally sing. All of this is not strictly true. There is cross-innervation that has been discovered more recently, but for practical purposes, the recurrent laryngeal nerve innervates pretty much everything except for the cricothyroid muscle. Now we think about motion as involving abduction, adduction, and longitudinal tension, but when we move the vocal folds, the vibratory margin changes as well. So this dotted line is neutral position. I already told you that the cricothyroid muscle stretches the vocal fold and increases longitudinal tension. So as it does, the edge of the vocal fold sharpens, just as if you stretched a rubber band, it would sharpen and thin. The posterior cricoarytenoid muscle, as I will show you in a minute, not only pulls the vocal folds apart, but also elevates. The vocalis muscle, or the medial belly of the thyroarytenoid, is in the same position as that white structure that was mislabeled vocal cord. So what happens when we fire that muscle? Think about it. What moves? Nothing. It's isometric. So the vocal fold bulks up and rounds, and that's what provides lateral resistance when we phonate. So when the left vocal fold hits the right vocal fold, it doesn't knock it to flutter out of the way, but holds its position. Of course, that strategy fails if the vocal fold is paralyzed and can no longer provide that isometric contraction and lateral resistance. So if you remember that the superior laryngeal nerve innervates the cricothyroid for longitudinal tension, and the posterior cricoarytenoid, the PCA, provides abduction, the rest of them all provide adduction. Again, anatomists are not overwhelmingly imaginative, so the posterior cricoarytenoid goes from the posterior aspect of the cricoid to the arytenoid. When muscles fire, they shorten, and because of the curve and shape, the vocal process and the vocal fold are raised and rotated out a little bit. The medial belly of the thyroarytenoid, also known as the vocalis muscle, we have already talked about. There are also other parts of the vocalis muscle that we won't address today. The lateral cricoarytenoid brings the vocal processes to the midline, after which we invoke the interarytenoid muscle, which gives us medial compression. Now, ordinarily, those two muscles work in concert so that the cartilaginous area of the vocal fold comes together over a fairly broad surface. Who cares? Well, we do. All of the laryngologists and many of the speech pathologists in the room have dealt with patients who have recurrent granuloma. an annoying inflammatory lesion. We treat the people for reflux, we operate on the granuloma, and it comes back. If you do frame-by-frame analysis on many of those people, you will find that the reason that they have granulomas here near the tip of the vocal process is that they have an LCA, lateral cricoarytenoid muscle dominant closure pattern, so that when they adduct, the vocal processes strike, and then the rest of the cartilaginous portion closes. It is very difficult for a speech-language pathologist to train that away. However, if you put some Botox in the lateral cricoarytenoid muscle, they can't do it. They get a broader closure, and speech-language pathologists are quite good at training them how to maintain that when the Botox wears off. So that's one of the treatable and identifiable reasons for recurrent granulomata. And of course, the cricothyroid brings the cricoid and thyroid cartilages closer together. As that happens, the cricoid rocks back in the cricoarytenoid joint, taking the vocal process further away from its attachment in the thyroid cartilage and lengthening it. And just as if we lengthen a string, it gets higher. That's not exactly why it gets higher. It gets higher because we're exerting subglottal pressure over a larger surface area, changing the initial condition so it can open and close more quickly, but that's how and what structures are involved. And they frequently are afflicted by pathology. Superior laryngeal nerve paralysis, cricothyroid muscle weakness, is quite common. The extrinsic muscles of the neck, those muscles on the outside, the ones that stand out on your average mediocre Held-in tenor. Anybody still awake? Anybody other than singing teachers have any clue what a Held-in tenor is? Jokes are hard in this crowd. Those muscles are responsible for vertical laryngeal position. In an untrained singer, the larynx goes down when we sing low notes and rises up in the neck when we sing high notes. In a trained classical singer, it maintains a relatively constant position, usually slightly below neutral. If it can't do that, and if it can't maintain perfect symmetry, symptoms occur. These are strap muscles. This is a cut strap muscle. This is the thyroid gland, here, in this area. I won't ask for a show of hands, but statistically, several of you in this room have had thyroidectomy. If the strap muscles are cut to make the surgical access easier, when they heal back together, they shorten slightly, and when the larynx drops, it tilts a little bit. And for an elite singer, that creates problems, even without damaging the superior laryngeal nerve. You wouldn't think a 1/16 of an inch would make a difference. How about if you put a 1/16 inch lift in one shoe of a marathon runner? Hip and knee pain halfway through. So it does make a difference. It's not singers being fussy. It's anatomic. So surgeons, especially in performers, should make every effort to retract, not divide these muscles. The inside of the larynx consists of true and false vocal folds, a ventricle, and a very complex mucosa. This again is anterior, posterior, the larynx split down the middle. We try not to do that except on selected attorneys and administrators. Inside are the true vocal folds, the false vocal folds, and the ventricle. Of course, there's the epiglottis and there's the airway. This is the same structure from the front. Here's the airway. Here are true vocal folds with the vocalis or medial bellies of the thyroarytenoid. Some lateral bellies in some people with extensions into the area of the false vocal folds, and the ventricles. Please note that although we are used to looking at two-dimensional pictures of the vocal folds from above, the vibratory margins are not two-dimensional structures. They extend in some people for several millimeters. The contact surface is more akin to two fingers coming together than two pieces of paper. Note too the convergence of this system. This steeple shape is extremely important to the aerodynamics of the system. As many of you remember from physics, when you have any flow system, air in this case, and it passes through a resistance that generates vortices, little whirls downstream, this is one of the structures that's primarily responsible for the aerodynamic behavior of the system. And if we alter this convergence, for example, by putting in a thyroplasty implant that is too big and squares off this convergence, we alter the efficiency of the system substantially. From above on the strobe, it looks like they have great closure, but their phonation threshold pressures are up, and it's effortful for them to phonate because of disturbance of this anatomy. The vocal folds may be divided into a muscular membranous portion and a cartilaginous portion. The muscular membranous portion is about 50% at birth and about 3/5 in adulthood. We used to be trained to think of the muscular membranous portion as phonatory and the cartilaginous portion as respiratory. This is a picture of a normal human larynx. Again, muscular membranous, and back in this area and partly hidden are cartilaginous. We know that in pathologic circumstances, the cartilaginous portion can serve as a very effective oscillator. Many of the physicians in the room have seen people with severe glottic webs, sometimes obliterating the entire muscular membranous vocal fold, yet the patients phonate quite clearly. Perhaps in a slightly higher fundamental frequency than normal, but quite clearly, if we look at them with the stroboscope, there's what looks like a very robust mucosal wave from the cartilaginous portion. The contributions of the cartilaginous portion in more elite phonation have not really been elucidated well. I suspect on the basis of no evidence whatsoever that this area of the vocal fold probably does play a role in elite singers. So until we know more, one might consider treating the mucosa along the cartilaginous portion with the same respect that we show for the muscular membranous portion, and not doing what is done traditionally, which is going in with a laser and burning out whatever happens to be there because it's not on the muscular membranous vocal fold. I don't, unless Johann has found something in the last year that I don't know about, and he just said no. I don't think we know enough to abuse this area of the larynx unnecessarily. The mucosa creates the smooth, lubricated contact surface that allows our vocal folds to come together and, as importantly, pull apart with a minimum of difficulty. The epithelium is different from the rest of the respiratory tract. Most of the respiratory tract contains pseudostratified ciliated columnar epithelium, but if you had little hair cells, little cilia, smashing together 200 times a second, those little hair cells wouldn't survive very long. So the mucosa over the vibratory margin is specialized. It's stratified squamous epithelium. The lubrication comes from mucinous glands and serous glands. They control viscosity. Many of the things that we think of as causing dehydration, for example, antihistamines, don't necessarily dry us. They shift from a serous to mucinous predominance, thickening the lubricant, which is just like thickening the oil in your car engine. It doesn't work efficiently, and the vocal folds can't separate the way they're supposed to. So when we hydrate, one of the things that happens is we're helping to shift back toward an appropriate mucinous-serous balance. The mucosa overlying the vocal folds is not simple wet stuff as we find on the inside of our cheek, on the buccal surface. It is much more complex than that, and thanks to Minoru Hirano's work in the mid-70s, we know a lot more about it. This is one of Minoru Hirano's slides. I'm not sure whether his son Shigeru will be with us this week. I think so. But the Hirano family are major contributors to our field. This is a vocal fold cut face on. So this would be the left vocal fold, the right vocal fold would be over here. The layers contain an epithelium, superficial, intermediate, and deep layers of lamina propria and muscle. This is the vocalis muscle, or medial belly of the thyroarytenoid, to which you were introduced previously. The epithelium and superficial layer of lamina propria, also known as Reinke space, move to form the mucosal wave from inferior to superior. The intermediate and deep layers together form the vocal ligament, and they are that white structure that was mislabeled vocal cord, around which the vocal fold is built. They form a transition layer between the epithelium and superficial lamina propria and the muscle. As it happens, the epithelium and superficial layer have few fibroblasts and other cells that form scar, although they are rich in materials necessary for healing. The deeper layers are rich in scar-forming potential, the vocal ligament and muscle. So you now understand anatomy in layers, physiology in layers, muscle with lateral resistance, superficial with a mucosal wave, healing in layers, and it didn't take us long to figure out that pathology should be analyzed in layers. Most benign pathology, nodules, cysts, most polyps, involve the epithelium or superficial portion of the superficial layer. So we developed fine, delicate instrumentation and new surgical techniques to permit resection of the pathology without disturbing adjacent underlying layers and provoking fibroblast proliferation that obliterates this elegant structure that we cannot recreate. And that, in a nutshell, is modern laryngology, and certainly modern surgical and medical diagnostic laryngology. How many of you lie awake at night wondering how the epithelium is attached to the superficial layer of lamina propria? Well, as it turns out, there's a basement membrane, just as there is basement membrane most other places. Do we have any residents with us in the audience today? Well, too bad, but we have lots of former residents. If it creates any extra humility, discovery was Steve Gray's resident research project at Iowa. Pretty elegant stuff. The basement membrane is pretty complex. It has type 7 collagen loops that go back up and reinsert into the basement membrane, through which pass type 3 collagen fibers, and that linkage is why the epithelium doesn't fly off. Of course, if we have a basement membrane disease like dermolysis bullosa et dystrophica, the basement membrane can fly off, just as skin can detach elsewhere on the body. That happens. The distribution of the linkages in these structures and the various proteins and other substances that are responsible for healing are controlled genetically. Once again, who cares? Well, let me throw something out to you. Not fully proven, but I quite believe it. So this one's for the speech pathologists. We see kids with vocal nodules. The kid comes in, you talk to the kid yells, the mother yells, the aunt yells, everybody in the family yells. You say, no wonder the kid has nodules. Everybody yells, and you treat the whole family. This is Philadelphia. We'll talk about more how great Philadelphia is tomorrow, but we have 500,000 Italians in South Philadelphia. If you go down and stand in the middle of a street in South Philadelphia in the summer, you can hear the dinner conversations for 6 blocks in all directions. How come only one kid gets nodules? It's more than behavioral. I believe that we're dealing with genetic predilection in this area, and that also probably is why some people can go out and sing in rock groups as teenagers and end up being John Bon Jovi or Bruce Springsteen, and most of them end up hoarse and are waiters or laryngologists. So anatomy is not just esoteric. We use it every single day in the office and in the operating room. The vocal folds form the primary oscillator of the vocal tract. They make a noise somewhat similar to a trumpet mouthpiece with lips buzzing on it. That sound passes through our resonator system. In order to be created in the first place, it requires power. Something has to set the vocal folds in vibration, just as something has to set lips in vibration against a mouthpiece. That infraglottic vocal tract is what singers call the power source. The term glottic is interesting. You remember I told you that anatomists are not particularly creative thinkers? I like to fantasize that this was the exception. The glottis is the space between the vocal folds. The whole system is referred to as glottic at the level of the vocal fold, supraglottic above, infraglottic below the vocal folds. There is no glottis. It's a space, and yet it's the referent for our system. So, how does it work? How do we speak? How do we sing? All of the things that we talked about work together, and that requires a brain. Even in tenors, a brain is a necessary component of the system.
Hey!
We could easily spend hours talking about neurolaryngology, our newest subspecialty. We won't, although I'd love to sometime. But think about this. You want to say something or sing something, but even say something because you target a pitch when you're about to talk. You draw on auditory memory. You define what you want to say. You preset everything that we've discussed. You utter a sound, and within milliseconds, by auditory feedback, you adjust to target and create the intended sound. And if you are deprived of auditory feedback, you use tactile feedback. Singers are trained to sing by ear, so when you're in a choir or with a loud orchestra or singing outdoors, you can control volume by feel, even if you can't hear yourself accurately. An enormously complex system. And there are other great complexities. There are people who study things that sound esoteric, like the periaqueductal gray matter. There is a little area in the brain where the pathways for respiration, phonation, and emotion converge. I haven't proven this, but we have looked at it in the office. I believe that people who have strokes that involve that area are more likely to be the people who are relatively monotone and in whom we have a great deal of difficulty restoring prosody. Whereas if that area of convergence and control is spared, I think that we do better, but that too requires more evidence than we have. For those of you who are still awake, you are inspiring actively, and then you relax. And the recoil of your thorax and rib cage lets out some of your air. I, however, am up here pontificating, and I am expiring actively. And that is what actors and professional speakers and singers do. And if they do it right, they use their bodies more than their neck muscles and laryngeal muscles to do that. We think of the diaphragm in science as an inspiratory muscle, although performers tend to use the diaphragm as a synonym for the whole support system. It shouldn't be. And other muscles, including the external intercostal muscles, also help us breathe in. Also not strictly true. In a nice paper years ago by von Euler and the Anderson and Johann Sundberg, it was demonstrated that the diaphragm also is activated during elite singing, during expiratory activities, and may be part of the control valve that helps modulate subglottic pressure. So it's all a little more complicated than it sounds. Expiration is intrinsic to what we call support. So if you want to squeeze air out of a balloon in a controlled fashion, you fill the balloon and you push with your hands a little bit. That is, sorry, physics again. You are decreasing the size of the container and therefore, with volume constant, increasing the pressure of the gas. And if you cheat with your hands in a little bit at the bottom, you're pushing the gas out toward the top. And if you want to do that, do you want a half-empty floppy balloon, or do you want a really full balloon? A full balloon, you almost have to think about bringing your hands together and almost don't have to do it. So that's why teaching support is very controversial, but there are some basic physical facts. Number one, you need a reservoir of air in the thoracic area. No matter how much abdominal breathing, inspiration and expiration you're doing, it has to push against something. So that's for sure. Number two, one way or another, you have to decrease the size of the container to increase the pressure and create subglottal pressure. And we do that using our abdominal muscles and our internal intercostals and forcing abdominal contents up and pulling the rib cage down a little bit and making the air space smaller to increase the pressure just as you would with a balloon. So once you've created subglottic pressure, what does that do? Let's arbitrarily look at vocal folds together. We want to push them apart. When subglottal pressure exceeds the adductory force, the force with which the vocal folds are held together, the vocal folds separate from the bottom up and from the back forward. When the air flows, the combination of Bernoulli effect, that force that sucks you into a passing truck or pulls your shower curtain in, combined with the elastic properties of the tissue, forces the vocal folds to close, again, from the bottom up. This difference between the top and bottom of that thin vibratory margin is called a vertical phase difference and is essential to efficient phonation. So if we have vocal fold swelling, edema from allergy or premenstrual hormonal changes or other factors, and this is impaired, so too is voice efficiency. And we used to think that all of this was entirely mechanical, and then I think it was Ira Sanders who came along and discovered selective differences in denervation between the upper and lower lips of the vibratory margin, which we still don't understand. Once you've made that sound, which is disturbingly like a trumpet, I used to be able to do that. Thank you. I assumed that that was a demonstration and not a commentary on the lecture. That sound, which is fairly boring acoustically, passes through our infinitely variable system of interconnected resonators and comes out looking like a nice Pocono mountain range. This is all Johann Sundberg's work, and we'll hear more about it later. This is just the introduction. The peaks in this lovely mountain range are called formants. And those formants are responsible for a lot of things, ranging from vowel intelligibility to our ability to hear voices over noise. The first couple of formats are particularly important for vowel intelligibility, but there is also a singer's formant cluster of particular interest to us. Some of you knew Pavarotti or heard him live in relatively small rooms. He did not have a particularly big or loud voice, but he could be singing and you could be stuck out in the hall and you could hear him over everything else because of ring. When a trained speaker goes to a football game or a bar, he or she can be heard over the noise without strain and come out without being hoarse. That is using what people who use their voices call ring, and what we call a resonant characteristic called the singer's formant cluster, involving in males the third, fourth, and fifth formats, which kind of work together, and in high females more the fourth and fifth formats. But Johann may go over this because it's a little different from what we understood a few years ago. Nevertheless, it's important. We can measure it, we can train it, we can help restore it. We can't necessarily make it Pavarotti quality, but we can usually make it better than it starts in the untrained case. Furthermore, there is a correlation between the center frequency of the singer's formant cluster and voice classification. And I remember well at Juilliard the first time Johann demonstrated this with a synthesizer. Now, the singer's format is more or less 2.5 octaves above high C, middle C, 3.5 octaves. So you wouldn't think it made any difference, but if you notch filter it out, voices disappear. With Johann's synthesizer, if you keep everything else constant and just move the singer's formant cluster down 200 hertz, so we're still 3.5 octaves above where you'd be listening to a singer, you change the voice classification. You don't just change the ring and the ability to be heard. You change somebody from a mezzo to a tenor. We have lots more to understand about this as well, but it's a very important concept to which we will forever be indebted to Dr. Sundberg. So why do we care? We care because we're clinicians. How do we control these things? Well, fundamental frequency, you already sort of know. You fire your superior laryngeal nerve, you shorten your cricothyroid muscle, you tilt your cricoid against the thyroid, you stretch out the vocal fold. You now have subglottic pressure acting against a larger surface area. It's more efficient. The vocal folds are stretched, so the condition of the system allows them to snap back together more quickly, so they can do it more times in a second. The frequency goes up, and the psychoacoustic correlate, pitch, also goes up. How about intensity? Suppose you hear a wonderful lecture. At the end, you want to applaud. Do you do this? No. You put your hands far apart and snap them together. So too with your vocal folds. You increase your adductory forces, increase your subglottic pressure. All of it's under our control. Below the vocal folds, further apart than you would if you were soft. That is, you increase the amplitude of displacement from the midline. You've increased subglottal pressure, so you have a blast of airflow come through, and your vocal folds snap together, and you cut it off sharply, you get a little rebound, and that's how you control amplitude, hence loudness. We can, in the office, quantify most of this. We use a bunch of different instruments. One of them is flow glottography, which is particularly interesting. It helps us, through inverse filtering, understand the relationship between adductory forces and subglottic pressure, among other things. So if you have inefficient adductory force, who have breathy voice, which we all understand, and which we can measure and document easily and quickly on a patient. If you have pressed phonation, the sound of a baritone in a cafeteria full of singers, that advertising that he is indeed a baritone. You have pressed phonation. We also hear that in most of our people with structural pathology, such as nodules. Increased adductory force against which you have to work with increased subglottic pressure. If you go from pressed phonation to flow phonation, Dr. Sundberg has shown that you can increase the output of the voice source signal, the vocal folds, by up to 15 decibels. Now understand that most of our patients, certainly those with structural pathology like nodules and hemorrhages, get into our office because they were struggling to be heard. That's the basic fundamental commonality. So when we create a better resonance system with a good ring, they can be heard better. When we go from pressed phonation to flow phonation, which is what I hope I have been using, we get a 15 dB increase. Is that a lot? Well, remember dB are logarithmic. So if you go into a paper plant that has a machine putting out 90 dB, would be measured in dBA, but we'll stick with dB, and turn on a second one, what do you get? Not 180, you get 93. You turn on two more, you're now up to 96, but your hands are over your ears because it's gotten a lot louder. How many paper machines do you have to turn on to get a 15 dB increase? 32. So when speech pathologists and singing teachers bring people forward into the mask and get rid of tongue tension and improve the efficiency of the voice source signal, they are doing something scientifically demonstrable to be able to make their students or patients able to be heard without exerting excessive effort. And we can measure all of that and its progress. We can use spectrography, we can use any of the various acoustic analysis systems to measure acoustic outputs and to follow them. We can look at vibration with strobovideolaryngoscopy, which you've all seen and which I won't show today. We can look at muscle function and strength with electromyography, a very safe procedure in expert hands. And we can understand the control mechanisms which helps us to do what we need to do in our offices and in our studios, which is understand the entire system through a systems analysis. We need to understand the oscillator, the resonator, and the voice source. Usually all of them are malfunctioning. And we need to be able to analyze how and identify which one malfunctioned first and which ones malfunctioned as compensatory gestures so that we can restore the underlying defect in the system in an efficient and long-term fashion. That is, in addition to the art of hearing, whether it's in a singing studio or a laryngologist's office, we now have the technology to quantify and enhance our auditory analysis with quantitative data that allow us to treat better and to assess the outcomes of our treatment much more articulately. And all of that is thanks to the scientists whom you will hear for the rest of the afternoon.
Okay. Is this timer going to be reset? I won't look at it. So hello, everyone. My name is Liz Heller-Murray. I'm an assistant professor at Temple University here in Philadelphia, so welcome. Sorry about the rain. And I'm going to talk to you today about the neurological aspects of voice production. And so my purpose in this talk is to really help you understand as much as we can the basics of neural control of voice, so that when you go on to the previous and you go on to the future talks, you'll have a nice basis for that understanding. There are my disclosures. My research is funded by the NIH from NIDCD, as well as the ASH Foundation. So when we're talking about the nervous system, we can think about it as two anatomical divisions. We have the central nervous system, which is the brain, the cerebellum, the brainstem, the spinal cord, the subcortical structures, everything that's housed in bone, right? We have housed in the skull or the vertebral column. Then we have the peripheral nervous system. We have the 31 pairs of spinal nerves and the 12 pairs of cranial nerves. So as Dr. Sataloff very kindly set up for me, when we're talking about vocal control, what we're really talking about is just volitional motor movements. At the end of the day, what it comes down to for most of what we're doing, it is volitional control of motor movements. So let's make sure we understand how that works. So when we're looking at this brain here, one of the things that we're focused on when we're thinking about motor control is this blue area here, the frontal lobe. So the frontal lobe is really important for the planning and the initiation of voluntary motion, which includes speech and volitional control of breathing. And we're looking at this area right here of the motor cortex, which is where the signals for motor control are going to be sent from. And it's very nicely organized, where signals for example, that are sending motor movements to our toes are going to be very close to the ones that send motor movements to our feet, and so on and so forth as it works up the body. So it's a very nice system that we have in our brains. So how does this actually work? So when we're talking about things communicating in the brain, we're primarily talking about neurons communicating with each other. So here is an example of a schematic of a neuron here. We have the dendrites here, the soma is the body, and what happens is that it sends a signal down the axon to either the next neuron or to whatever it's connecting with. So I like to sort of take this into the room to understand a little bit more. If we pretend that this group over here is a neuron, and this group over here is a neuron, and if you want to send information over here, let's say I give you a pen, and I give you a pen and I said, I want you to get that information over there. You could pass it over, you could pass it over, you could pass it over, you could pass it over. Then we get to this gap, this synaptic cleft. We have this little space here in between them. You say, okay, I have this pen, let me send out these signals to you to let you know I have this pen. Send out these neurotransmitters into the synaptic cleft, send out the signals. You get those signals over here and say, oh, it's time for me to pass a pen. So you take your pen and you pass it and you pass it and you pass it and keep going. So in that way, the neurons can really communicate with each other by sending this action potential down the axon, and then when they get to another neuron, they send out these neurotransmitter signals to let the next neuron or muscle group or whatever they're communicating with know it's time to do their thing. And neurons are impressively long, many of them are. So here is we have the primary motor cortex. We have a neuron that's getting information from that primary motor cortex, and that neuron is going to send that information all the way down until at some point in this schematic where it's in the spinal cord. At that point, it's going to then send those neurotransmitters out, the information across the gap, to the lower motor neuron, what it's going to connect with here, and that's going to send that information to the muscle. So really, we're just, oh, sorry, my motor system's a bit off, so here we go. So really, in this particular picture, we're just talking about two neurons communicating with each other, right? We get a signal from the motor cortex, goes from the upper motor neuron to the lower motor neuron. So I like to also visualize that and think about what this looks like in a typical system and in a system where we have disruption. So here we have a typical schematic, and I believe this is an arm muscle. So we have some activation from our motor cortex. It's going down this upper motor neuron, sending that information, connecting to the lower motor neuron, that's sending information and having the muscle move. So what happens in a situation like this, where there's a spinal cord injury? So in this situation, the signals from the motor cortex are still sending. The people over here, this motor cortex, are still throwing their pens, but they're just not landing landing anywhere that makes sense because there's this divide there, there's a cut for whatever the reason is, and whenever that injury happened, at that point where the nerve is injured, the signals aren't going past that. So when you start to think about where injury can happen, whether it's really high up, really low down, you can see how that can result in very different outcomes based on where those signals are going. Well, I'm on to control of voice. So, now that we understand everything about motor movement, so we're good, right? Great, perfect. So let's now take that and put that into voicing, right? Because that's really what we're talking about here. So I like to take neural control of voice and break it down into 4 main parts as we go through how we actually voice. So we're going to start with respiration. So why are we breathing right now? Well, we're breathing just to live. And lucky for us, this is involuntary. So we don't need to worry about this, both in this room and for this talk. When we're breathing for life, it's involuntary, it's a very complex system. What I'm talking about is volitional control for speech. So, if I said I'm going to have everybody hold out an ah for as long as they can, everyone's going to immediately go, and you're going to take a breath first. You're going to prep for that. That is volitional control, where you're prepping your respiratory system to get ready for voicing. And as we will learn about, I believe, in the next talk more, and as we heard about a little bit, when we're talking about that, again, we're just sending signals to different muscles. In this case, the signals that we're sending are primarily to the diaphragm, as well as some other accessory muscles. So when we want to take a big breath to get ready for speech, when we want to inspire, our diaphragm contracts, and that helps pull the thoracic cavity out and down. Then we have some very cool physics things that we'll continue to talk about in future slides. But from our point of view, for this slide, how do we send the signal to that muscle to get it to move? Well, just like everything else, it's coming from the motor cortex. So same thing. We send a signal from our motor cortex to tell our diaphragm to contract. In this particular case, if we're talking about innervating, which means what's sort of causing it to have this motion of the diaphragm, we're talking about the phrenic nerve. So the phrenic nerve connects around C3 or C3, C5, which is sort of right up here. So motor signal, the motor cortex sends a signal, the upper motor neuron sends that signal down until it connects right, right in the neck there where it is close to the phrenic nerve. It sends the information to the phrenic nerve. The phrenic nerve then goes to a lot of different places, but one of them is also the diaphragm. So through that, we've just gone through signal, one nerve, one neuron, another neuron, diaphragm contracts. So thinking about this, again, from a disordered perspective, to think, well, how can some of these injuries in this area affect what we see in a clinic or how we understand sort of neurological control of voice? So the first one is, again, like I showed before, spinal cord injury. So here, I'm going to keep this one up here. This is our typical production. And here we have sort of an injury here, signal being sent, not going anywhere. So this could happen with the phrenic nerve. So you could be sending a signal telling the phrenic nerve that the diaphragm should fire, should contract. It's just not getting through past wherever that injury is. Another thing that could affect the phrenic nerve is myasthenia gravis. So this is an autoimmune disease that impacts the nerve communication. So in this case, there's no full injury or severing of the nerve, but the way that the nerve is communicating with the muscle is just not as effective. So it's a really complex system where those signals are getting there, but it's not quite activating the muscle the way it should. And then another one we see is multiple sclerosis. So here's one where when I previously showed you the nerves, we had looked only at this picture. What you see in this particular one is you don't have these nice white little hot dog bun looking things, which are called myelin sheaths. And they are actually very important because what they do is they help these action potentials that move down the neuron move faster. So let's look in this situation where there's no myelin sheaths there. And let's go back to our pens. Let's go back to our pen example. I'm going to give you a pen over there, and I'm going to say we need to get it all the way to the other side of the room. And the only way you can do it is hand it to the person next to you. It'll take a while, but it'll get there. So what if I give you a pen and I say, you know what? You can skip it over 3 people. And then you take it, you skip it over 3 people. You take it, you skip it over 3 people. It's going to get much faster down to the other end. And that's essentially what's happening here. The action potential, because of these little sort of fatty myelin sheets here, actually is jumping from here to here to here to here to here, and so it moves much faster down the neuron. Now you can imagine that in something like multiple sclerosis, where there's this nerve demyelination, the signals are still getting through, but that really slows them down, and you can see that that's part of the effect. And if that happens in the phrenic nerve, again, we're talking about that impact on the diaphragm. So moving from respiration, I like to lump vocal fold adduction and vocal fold tension into one for the purpose of this talk, because what we're talking about here is we're talking about the vagus nerve, even though we're doing a lot of different things. So just to pull this back up over here, it's a slightly different picture than what we saw before. Here we have the motor cortex here. Just to acknowledge, though I didn't go over it before, but as Dr. Sataloff mentioned, you don't just start voicing. You think about it, you initiate it, you plan, all that stuff also happens a little bit further in the premotor cortex here. So in this case, when we're talking about vocal fold adduction and abduction, opening and closing, we're talking about vocal fold tension, what we're saying is we're going to send signals from that motor cortex, and rather than sending them all the way down to sort of the spinal column where we had done before, we're actually sending them to a cranial nerve, which is located in the brainstem. So the vagus nerve, which is the one that we're working on and focusing on right here, cranial nerve 10, it connects right here in the medulla. You can see here, the nucleus ambiguous is part of the medulla. And so now we're looking at a different view here. So now it's sort of, we took a cut and looked here, so you can see both, and you can see both motor cortices here. So, yeah. So we have a neuron which goes to the motor cortex, connects here, and at the nuclear ambiguous, which is again in the medulla, it connects to the vagus nerve. Now, the vagus nerve, as Dr. Sataloff had mentioned, is pretty fascinating because it goes to a lot of different places. And even as it's coming to the larynx and coming to innervate the larynx, it takes different paths depending if you're on the left or the right side. But yet it still manages to sort of come there relatively symmetrically. So there's 2 main parts of the vagus nerve that we're going to focus on. The first branch here is the superior laryngeal nerve, which you can see on the left and the right side. Sort of comes off and looks pretty similar on those 2 sides. We're going to focus that more superiorly. Then we have the recurrent laryngeal nerve, which on the left side comes all the way down around the aortic arch, and then it comes back up over here. And on the right side makes a little bit more of a detour, but not quite as far. And then they end up down over here. So when we're talking about the recurrent laryngeal nerve, the branch of the vagus nerve, and again, if you remember what Dr. Sataloff said, we're saying everything but cricothyroid, right? That's really the best way to think about this in terms of how we're phrasing things at the moment. So it is going to be responsible for adduction, abduction, and a little bit of tension and relaxation from the TA muscles. But again, we're primarily thinking those primary adductors, the thyroarytenoid, the intrarytenoid, the lateral cricoarytenoid, and the abduction, the posterior cricoarytenoid. So those are the recurrent laryngeal nerve. When you're talking about the superior laryngeal nerve, you're primarily talking about the cricothyroid muscle. So again, we have here, this example just coming through, cricothyroid muscle. And when we think about pitch, I know with this audience we tend to often think about singing and things along that note, but I also just want to remind you that pitch is so important for so many different parts of speech. So this is an example of pitch tracings of somebody saying, I never said she stole my money, I never said she stole my money, I never said she stole my money, right? Those are the same words with different pitch traces, different pitch emphasis. So solely through my pitch, I'm conveying a different meaning. So you can see the importance of pitch in also speech intelligibility and a lot of different things as we go through this. So to schematize this and make sure that we're all on the same page here. Motor cortex, sends a signal to the vagus nerve, which connects through the nucleus ambiguous, and, sorry, it seems to be a little cut off. I don't know if I have any control of that, but, and then we're talking about the vagus nerve with those two main branches, with the SLN, where we're talking about pitch changes, and the RLN, where we're talking about abduction and adduction. There we go. So when we think about this in terms of things that you may see in the upcoming days when we're talking about in terms of disorder, in a vacuum, if we were going to say these things didn't have any overlap, SLN injury is going to end up in disordered vocal fold tension, so disordered changes in vocal pitch, whereas RLN injury is going to be ending up in vocal fold paralysis, paresis, open and closed movement differences. So when we think about neurological voice disorders, these are a couple of them, but you might also notice that there's a couple other big ones that haven't been mentioned at all and do not fit very neatly into this nice schematic that I made in PowerPoint. So I'm going to give you a bit of an example in understanding how these work, but understanding that these are complex, but they are still sort of neural control. So what I haven't mentioned at all is the basal ganglia. So this is deep in the motor cortex, not in the motor cortex, excuse me, deep in the cortex, and it's responsible for the smooth movement and coordination. So when we think about this nice, easy motor cortex, vagus nerve, laryngeal muscle, that's great for a go signal, right? That's great for, I need to do a movement, make a movement. But the reality is, for our movements, especially for our voice, they're extremely coordinated and controlled and complex. And because of that, there's a lot more integration of other control systems like the basal ganglia. So rather than jumping right to the musculature, what happens is that the motor cortex sends the signal that it wants to send to the basal ganglia, which then sends that to the thalamus, which then sends it back to the motor cortex. So in the process of this loop, it gets refined and controlled, and the basal ganglia has two main pathways. It has a direct pathway that promotes movement, and it has an indirect pathway that suppresses movement. So when we think about that, we're going to focus a little bit just on the direct pathway, just for timing, and I can tell you a little bit about how that's disordered in Parkinson's, which is where we're headed with this. So I've stretched out the basal ganglia here so I can fit more things in it, because as you notice, there's a lot in that picture that we just showed. So we think about the circuit. The important thing to remember is that the thalamus wants to send the motor cortex a go signal. That's what it likes to do. It's saying, you're ready to go, here's your movement, let's move. So the reason that we're not moving all of the time, because if the thalamus is constantly sending this go signal, we'd be in constant motion, is because there's an element of control. And that control, in this case, is coming from the basal ganglia. So the reason the thalamus isn't always sending its go signals is because this section of the basal ganglia, the globus pallidus internus, is sending a stop signal. So that is essentially sending a signal to the thalamus that says, I know you want to go, but not yet. Hold, we're not ready yet, hold. So that is controlling that, and it's waiting for its own signal. And so that's what's happening in the direct pathway, is when you're ready to send a signal, the motor cortex then sends its own go signal to the striatum, which is also part of the basal ganglia, which then sends a stop signal to the globus pallidus, which then stops its stop signal to the thalamus, if you're with me here, right? Because remember, these things, they're either telling things to go or stop. So when this loop gets activated, essentially the thalamus is let free. The thalamus is no longer being told to stop, and then it can send that go signal. Now, I mentioned Parkinson's disease, which is why we started talking about the basal ganglia. And when we think about Parkinson's disease, we know that it's a neurodegenerative disorder, and if we don't know a lot about it, we know that the word dopamine comes up when we're trying to understand it, right? And so dopamine is a neurotransmitter, and when we think about this loop, we can think about dopamine as a way that is helping this loop do its job, right? So the dopamine is helping, in this case, helping that stop signal be removed from the thalamus so it can send its job. It's just helping this loop work more effectively. So if we take some of that away, which is what starts happening in Parkinson's, this loop is just not as effective. right? So again, if I gave you 100 pens and I have you throw them over on this side, and every time you catch a pen, you put your hand up, you're putting your hand up all the time. It's great, this loop keeps going. If I take away 95 of those, you're still gonna get the signal, but it's a lot less, it's a lot weaker, and it's gonna be more intermittent. So this is what happens sometimes when this particular loop is disrupted, because there's not enough dopamine, where that go signal is there, and then it's kind of gone, and there, and kind of gone. So sort of some of that jerkiness that can come in. I'm not gonna go into the indirect pathway for time, but the indirect pathway is even more complex, and it's the opposite, right? So the indirect pathway keeps you from constantly shaking when you wanna be still. So the same sort of thing. There's a lot of inhibition, there's a lot of excitation, it keeps non-motor movement. Like if I'm doing this with my thumb, right, my direct pathway is helping my thumb move, and my indirect is keeping my index finger still. Because those are really, really near each other in my brain. So those things are really integrated together. The other disorder I want to talk about is laryngeal dystonia, previously called spasmodic dysphonia. And this was also considered a basal ganglia disorder until about 5 years ago. So in 2020, there started to be some really amazing research that started coming out more and more that shows that, yes, the basal ganglia and the thalamus are still very much involved, but it's more of a network disorder. And there is differences that they've seen in the structural and functional connectivity. There's abnormal neurotransmitter function resulting in some sort of loss of inhibition. There's differences in motor and sensory function, so it's a very complex neurological disorder of voice that is still a lot of interesting things are coming out about it, but you still have this control center at the center of it, but it's more complex than just this quote-unquote simple loop that we were talking about. So we've been talking about motor control, and for the most part, a lot of voicing is motor control, right? You're activating your muscles to do something that you want them to do. But as we're speaking, as we're voicing, we are also monitoring what we're saying. Frequently that is auditorily, although sometimes it's somatosensory as well. And so here is that figure I pulled up from before, where we were looking at the different pitch traces. And what they were doing during the study is they were looking at the pitch traces and they were looking to see which areas in the brain correlated with pitch changes. And what they found was, of course, you have this activation in the motor control area, not surprising at all. And there was also a lot of activation in this area, which you may be saying, Liz, you haven't told me what that part of the brain is. And that's true, I have not. That's because that has to do with audition. So that's the temporal lobe, and it's the primary auditory receptor. Just a lot of higher order auditory processing, but it is also very active when we are speaking. And that's because we're constantly processing that sensory information. And not only do we process that, in this case in the auditory, in our sort of auditory reception, we also then process that and integrate it with any sort of somatic succession that we have, and then can send motor commands if we need to correct them. So if you look at this sort of experiment, this is an experiment where the person comes in and they're holding out an ah, and they're hearing themselves back in near real time. What they don't know is that there is a subtle change to their pitch that might happen at some point that they'll hear in their headphones. What we are able to do as humans who can control our voice is we hear this sudden increase in pitch, and our brain realizes that that's a mistake. Because we didn't change our pitch. I didn't send a motor command to change my pitch. I don't know why my pitch is sounding different, but the body makes mistakes. I'm great at correcting them. So what I can do then is send a corrective motor command to decrease my pitch. So this shows us how quickly we can monitor and change our pitch in response to something that we think we've done. So when we look at individuals with voice disorders, so Dr. Stapp has done some really interesting work, where if you look at the typical voices, which are the blue voices here, sort of big patch of blue here, you see that typically when people hear an increase in pitch in their headphones, that sounds like they were doing it, but they didn't mean to, they will decrease their pitch in response. Oh, I didn't mean to do that, that's a mistake, let me decrease. What you see in the individuals voice disorders is it's all over the place, right? Some people compensate as well. Some people don't really respond. Some people follow. So there's this thought that they're investigating is this development of these hyperfunctional voice disorders, nodules, muscle tension dysphonia, is this also difficulty with this somatosensory integration? Difficulty hearing a difference and then taking it and sending a corrective motor command. So, if I've completely lost you, for this last minute and a half, I'm going to summarize everything, so we're good, okay? Big picture. Motor signal is sent from the motor cortex. We send that signal to the basal ganglia. We refine it, we have this nice coordination, we send that signal back, and then we send it to the muscles. Which muscles? Depends what part of voicing. If we are on respiration, we send that signal through the phrenic nerve to the diaphragm. If we are abducting or adducting or changing our pitch, we send that signal and it connects to the vagus nerve and then continues on from there. And as we're talking, we're continually monitoring ourselves. We're sending that sensory information back into our brain. We're sending that information about what it sounds like, what it feels like. And then if we need to, we're sending corrective motor commands for the next time that we're ready to voice, in the next couple milliseconds. And we can continue to monitor that as we go. And that is the neural control of voicing. Thank you so much.
And breathing and voice. The topic of my talk, okay. I should just, breathing apparatus has the task of squeezing and expanding the lungs. And as you squeeze the container of air, then the pressure in the air gets higher, of course, and as we know from bike and other pressures of air. The pressure pressure under the glottis is called the subglottal pressure, and subglottal pressure is very, very important to voicing. So how do you measure it? It is a child's game to measure it. You just take a little tube and fold it into the shape of a U, and you have some water in it, and then you put your pressure into one end, and then you see what happens with the water level close to the pressure and further away from the pressure. And the level difference there between the two water levels in the U-shaped tube, that is our pressure measure. So you measure pressure in centimeters water column, like that. Okay, breathing behavior is considered crucial to voice. And why could that be? Well, you have already heard about it, and I will talk about some reasons for it. Mechanism, the vocal folds caused to vibrate by airflow, and airflow is produced by subglottal pressure, and the subglottal pressure is determined by three factors: muscles, and elasticity or recoil, and then gravitation, which is very difficult to get rid of here on this planet. Okay, there are two main systems, as we heard before. The muscles between the ribs, intercostal, and there are external and internal. They expand and they squeeze the rib cage. And let's look at that to begin with. The external, they go at an angle. So when they contract, they tend to raise the ribs. And then, if you see the cross-sectional area, when I have the ribs down, it is small, and when I have lifted them, it is bigger. So that is an expansion. And then the internal, they are more perpendicular, so they squeeze and put the ribs back in the lower position. Okay, so that is the story with the intercostal muscles. And then the diaphragm, the abdominal wall, that is lowering and raising the floor of the rib cage. So the diaphragm is located like a bowl shape there in the bottom of the rib cage. Here you see it. It is originating from the lower part of the rib cage, and then it goes up into a vault, and when you contract it, this muscle, as all other muscles in the body, if you contract it, they try to get shorter. So when you should make this vaulted shape shorter, it must go down, it must flatten. So that means that when you contract the diaphragm, it lowers the floor in the rib cage, and expands the lungs, because the volume around the lungs will be bigger. Okay, abdominal wall. Well, diaphragm contraction expands the abdominal wall, and contracting it against contracted abdominal wall. Then you try, the diaphragm tries to push down, but the abdominal wall says no further down here. And what could the diaphragm do? Well, it is just to widen the flanks. Abdominal wall is the other, that is the exhalatory force. And it tries to pushes the diaphragm up, because when you, what you have behind the abdominal wall is not very compressible. So if you put it in, the diaphragm goes up in the body. Okay, that's it. So, and as you saw a minute ago, we could see here a little portion of the mechanism, where you have the diaphragm there and rib cage and so on, and you see that it moves the floor of the rib cage down, and then the abdominal wall could push it up again. Okay, and then we could look at this. It's a very striking demonstration of the mechanism. If you lie down on your back and get your shoe on the abdominal wall to rise, then that means diaphragmatic contraction. And if you and the other shoe could be on the rib cage, and then you see what happens when you shift the contraction of the abdominal wall and let it out. Yeah, that's it. So we have the actors here, rib cage and intercostal muscles. They could expand and squeeze the rib cage, and then we have the diaphragm that on contraction lowers the floor in the rib cage and increases the volume around the lungs. So that is an inhalatory muscle. And then the abdominal wall tries to put the diaphragm up higher in the rib cage. Yeah. So you could remember that in the early days there were some people in the voice area who thought that the diaphragm was entirely neurally controlled and could not be affected by willfully control. And that is completely wrong, so you should convince those people not to talk about such things. It is just a mistake. Probably the hiccup is the cause of it. Okay, you could try to contract the abdominal wall, and the thing is that you make your abdominal wall hard, and then while you do, well, then you contract the diaphragm, and you co-contract your abdominal wall, so it sits there. And if you still can do that while pronouncing a soft S sound. It means that you have a low pressure in the lungs and you have a high pressure in the abdominal area. So, and of course, I invite you to test that by willfully contracting the diaphragm. Yeah, we can all breathe, and that is not news for you, anybody here, but yet many singing teachers and clinicians teach students how to breathe. So that is, could be a question to contemplate. There are several reasons for this, and one is this classical exercise trying to demonstrate. When you sing this and that's melody, then what happens in your body is that the subglottal pressure is following the contour of the melody. And it is also interesting to see the details. First member of the new harmony gets the highest pressure, even though it's not the highest note. So, and what are the typical ranges of pressure in the lungs, in the respiratory system? Well, when we speak calmly in calm surrounding, it's about 5, 7, 10 centimeters of water color. And shouting, then it may be going up to between 10 and 20. And in singing, we could imagine that it is about 5 or 7 and up to 40 or even 50 centimeters of water color. Okay, so reason 1. In singing, subglottal pressure needs to be tailored to the pitch, and this is a cornerstone why you need to be a good master of your subglottal pressure in singing. And you could imagine that if you stretch the vocal folds, they are less willing to vibrate, so you need a higher pressure to drive them to vibration. Okay, and ascending octave requires about double subglottal pressure. Interesting. So if you go 1 octave up, you need to double the subglottal pressure on average. Which is, so a change in pitch requires change of subglottal pressure. And pitch variation is of course wide in singing, high notes and low notes. So subglottal pressure needs to be controlled by the breathing apparatus, and that is an important reason for the importance of breathing strategy to singing. Now, if we do this, you close or open your glottis, that is opening and closing your glottis, and you inhale deeply and close the glottis and relax, and then open the glottis, and everybody will exhale. Because there is a recoil effect. When you have expanding the balloons, the lungs, it wants to contract. So we have a recoil that is expiratory at high lung volume, when you have much air in the lungs. And if you exhale deeply, close the glottis, relax, and open the glottis again, you will inhale. So that is an important thing, that if you have little lung, a low amount of air in the lungs, you have an inhalatory recoil effect. And of course the recoil will affect the subglottal pressure. So yeah, this is of course because the lungs and the ribcage are elastic. Okay, so let's see how much pressure this recoil force could use. Here we have lung volume in percent of maximum of what you could inhale, and if you go up to 100% after a deep inhalation, you may reach something like 30 centimeters of water column. a good thing, a good pressure for shouting. And if you have exhaled all you can, then you might go to minus 20, a suction pressure of about 20 centimeters. Do you see? Okay, I see. Yeah, that's okay. Okay, so that is a line. Now this line is where the recoil forces are 0, and that is a very important from lung volume from a functional and voice point of view. It's called the resting expiratory level or functional residual capacity, if you want. Men, look at this. Here the exhalatory forces are great. So if you want now to control the subglottal pressure, you need to do something, because the recoil automatically produces a high pressure. And here, when you come to low lung volumes, then the inhalatory elasticity forces take over. So now, how does that feel? Well, inhale and make a relaxed sigh. Yeah, I'd like if some you would like to comment something in complete hopelessness. Everybody then very accurately reaches their resting expiratory level. Okay, so we go on. Now, if we want to sustain a soft tone, we need a low pressure. Now, the target pressure for that is then a low value, and the recoil pressure is much too high. So what you have to do, well, you have to contract your inhalatory muscles at high lung volumes for soft, for producing low subglottal pressure for soft tones and low tones. And that is what people talk about in vocal pedagogy, in alare la voce. That means, in physiological terms, contract your inhalatory muscles such that you reach your target pressure. And then here, when you come, when the recoil, when your recoil force has passed the target pressure, then you need to take over with the exhalatory activation of exhalatory muscles. So, and note that as soon as you sustain the tone, you decrease the amount of air in the lungs, so the recoil decreases all the time, and that is then something that you don't need to pay so much attention to if you are only speaking. Yeah. Subglottal pressure from elasticity forces are quite big, as I said, and when you speak, we usually use a very small amount of lung volume. Take just a half a liter or maybe a bit more, and then when we come to the resting expiratory level, then we take a breath, and that nobody minds such breath pauses. But if we want to have a high pressure for long, high tone, high-pitched tone, then you might need to contract your exhalatory pressures also at the beginning at high lung volumes. Okay, so it's a delicate interplay here between inhalatory and exhalatory muscles, and you need to match it to the pitch that you are going to sing, because that needs different pitches needs different subglottal pressure, and also how much air you have in the lungs. So the reason to reach the target subglottal pressure, singers need to compensate a huge variation of recoil pressures, and they decrease, and these pressures decrease with lung volume. Okay, So that was the muscles, and then the recoil, and now the reason number 3 is what happened with the what you need to take into account when you vary lung volume. I have been touching on that topic for a while now. Lung volume is how much air you have in your lungs, measured in liter frequently. Okay, now lung volumes, that is generally measured in percent of vital capacity, and vital capacity is the maximum amount of air that you can inhale and exhale. That is your range. And short people have small lungs and tall people have big lungs. So it is quite interesting or relevant to normalize, not to measure how many liters you can inhale, but rather what your vital capacity is, where you are along your vital capacity. Yeah, okay, this is a curve of a deep inhalation and exhalation. So you have the vital capacity running up and down there. Okay, calm breathing starts, inhalation in calm breathing starts from resting expiratory level. So that is the resting level that we use, and that means that inhalation is active and exhalation is passive. So here we have a great difference between calm breathing and singing, of course. In speech we have rather moderate variation of lung volume and rather reasonable subglottal pressure, so that is not so much to train for, but for singing we need to go to higher pressure, high lung volumes, and then that means that you need to deal with much more recoil forces, and that is special for singing. Yeah, okay, so how does it feel to phonate at lung volumes below resting expiratory level? So then it is, the task is to take a breath and to make a hopeless sigh, and then to start speaking after without inhaling. There, and you feel how it feels to speak with low lung volumes below resting expiratory level. It is not nice, it is uncomfortable. So people don't want to use much the lung volumes below resting expiratory level. So look at this. In singing, phrases can be very long, and it could be also very loud, so it takes a lot of air. So classically trained singers, they use a lot of lung volume range. These are measurements of professional singers, up to a big deal of the vital capacity. This is rare here in this case, and this is 40 centimeters above red. Okay, and here in conversational speech, it's just a small variation range, and country singers on popular music singers generally don't use so much lung volume as classically trained singers. So classically trained singers need to deal with very strong recoil forces. That is the example. And now I would like to disturb you with a little small parenthesis, and that is that in singing phrases, the phrases in singing are typically about 10 seconds long, and that is mostly quick inhalations and slow exhalations. And it turns out that slow exhalation and quick inhalation, variation of inhalation and exhalation, is beneficial for health, and that is the end of this little parenthesis. Okay, so also posture affects resting expiratory level. If you have a slumping posture like that, you have you squeeze the abdominal wall into the rib cage, so you don't get so much air volume to inhale as when you're up straight. Now, finally, the gravitation is the reason number 4, and it has a very interesting and highly relevant connection with the larynx and phonation. The lungs are quite big, and they are hanging in the larynx, and the lungs, therefore, or the trachea, wants to pull the larynx down. The tracheal pull is a mechanical link between the breathing system, and the interesting thing is that the tracheal pull tends to abduct the vocal folds to separate. So it has been found that the tracheal pull, that means that is big at high lung volumes, and when the diaphragm is low, you have a lot of tissue that is hanging, and when you approach the end of the phrase, the diaphragm is higher, so some of the weight is then carried by the abdominal wall, abdominal content. Okay, so it turns out that if you meet pressed phonation, people with pressed phonation, one thing to try is to encourage them to start the phrases with bigger lung volume, because then the diaphragm is far down in the body, and you get the tracheal pull that tends to reduce glottal adduction. Okay, that is it, and then a consequence of this is it matters if the melody direction is descending or ascending, because if you have descending, if you start with the high notes and go to lower notes, you get the high notes with high lung volumes and the lower notes with low lung volumes, and the tracheal pull helps you to avoid pressed phonation over adducting at high lung volume. So that could be a pedagogical trick. Look at this, a lung volume like this, phonation going on, then you use the air and get less and less lung volume. So high pitches are produced with high lung volumes if you have a descending direction of melody. And that could be good for trying with people who have too much glottal adduction on high pitches. And high pitches produced with low lung volumes at rising melodical direction. So that might be better an exercise to try for voices who who should reduce the breathiness in voice. By the way, this classical exercise I mentioned before, and it illustrates the need for singing to always vary subglottal pressure, and not only that, because many times, it is common that you start with doing this legato, and then it means that you need to raise the subglottal pressure in pace with the pitch. But if you do it staccato, the truth is that you need to lower the subglottal pressure to 0 between the tones. Otherwise it sounds like ah, 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 instead of ah, 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 ah. So you can't have a subglottal pressure above 0 if you open the glottis, because then you lose your air. Okay, so the voice onset can be of different kinds. So you can have the hard onsets, where you start with adduction and then comes the subglottal pressure, up, up, and then vocal fold vibration comes after a little while. And then you could have the staccato, up, 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 and then you actually have synchronization between glottal adduction and subglottal pressure onset. And then you have the breathy phonation, ha, 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 ha. When we laugh, we do that. And then we start with subglottal pressure, and airflow comes first, and then glottal adduction. So this is an example of the amazing synchronization skills that we have. Yeah, that was it, and synchronization of adduction and subglottal pressure. Okay, that's it. So that was my little presentation about the breathing, summarizing it. There are muscles, two group of muscles for inhalation and exhalation. We could do it by only the rib cage muscles, and or do it with the abdominal and diaphragm conversation. That is complete systems for inhalation and exhalation. And then the lung volume, elasticity forces are equal at resting expiratory level, under which it is inconvenient, uncomfortable to phonate. So small lung volume range in speech and large in singing means that if you are singing, you need to be skilled in quickly and accurately varying the subglottal pressure between targets. And tracheal pull is the mechanical system, mechanical connection between the respiratory and the phonatory system that makes the breathing strategy quite relevant for voice. Okay, that's it.
Basics of phonatory function and overview. Again, the structure of the vocal folds. You have the epithelium, the lamina propria, which is superficial layer, intermediate layer, and deep. And the vocal ligament is comprised of the intermediate and deep layer. One definition of the mucosa is the epithelium plus the lamina propria. So, one of the first topics to talk about would be fundamental frequency. It's the primary outcome variable. From an orientation point of view, again, this is the glottis, the anterior commissure here. This is where the vocal processes would be. So this is the membranous glottis. This white line bar here is to imagine what it looks like in the slice right through that, and it looks something like this, looking from the front, near the middle there of the membranous glottis, and where the phonation vocal folds are. Now, one of the questions that actually comes up, interestingly, how do you get the fundamental frequency from the period? Very straightforwardly. If you have a period of vibration from the beginning here all the way through to basically the beginning of the next cycle, and if that were to take 0.01 seconds, or 10 milliseconds, but 0.01 seconds, if you want to know what the fundamental frequency is for that, you just invert that amount of time. So the fundamental frequency would be 1 over 0.01 seconds or 100 hertz. So this is a very basic concept of figuring out what the frequency is if you know the period, or what the period is knowing the frequency. And of course that comes up at breakfast almost every day. The fundamental frequency basically then corresponds to the cycles of phonation.
Symmetricity, regularity.
Every time the folds open and then close and then open again, that would be one period between same phase. And then if you look at the cartoon, that this Hirano designation comes from looks like this. This is the classic cartoon. The yellow is the mucosa, there's the epithelium, and you have the muscle. And it goes from this convergent creation of the glottis here to a divergent. This is actually most open, and then it goes to a divergent shape, and this is the primary aspect. It's really important to have very pliable vocal folds so that they vibrate, such that you have convergent and divergent. Let's do this real quick so that we can pretend this is a workshop, depending on what kind of CEUs you need. So put your hands up like that if you would. And this will be the medial surface of the one fold and the other fold are together like this. This will be your inferior vocal fold surface. And it's now massaged completely. This will be your superior vocal fold surface. Now, don't do anything but this when you are showing people how the vocal folds work. Separate from the lower in your hand so that the fingers are still touching, and then go right to here. So this is the beginning of the opening. You don't see from above that it's separating, but it is. And then just go out and go to, touchdown time. Okay? Then just gently turn your hands and come back and allow them to touch here. And then allow them to just kind of fold together like that. Okay? Just do that. Do not do this. Or this. Now, Johann likes to do this, but he's got long arms. Big crowds and things like that. So, all right, please. When you're teaching, when you're showing, clients, when you're trying to explain it, okay. Please do that. Vocal fold length and contour relative to antagonistic actions, actually. You do have the cricothyroid muscles that we've talked about quite a bit that will elongate the vocal folds. But when the vocalis itself does contract, it will shorten the vocal folds some. And so that's antagonistic action. Most of our teaching revolves around efficiency relative antagonistic action. So when the vocal folds are short, the cricothyroid muscle is not contracted much. And then when you contract the cricothyroid muscle, the cricoid will pivot on the cricothyroid joint. The arytenoids are attached on top of the cricoid, and the attachment to the thyroid here is constant. So now that's going to elongate the vocal folds because the anterior portion of the cricoid comes up when the CT contracts. So that's the pitch lengthening aspect, and here is a demonstration of pitch vocal fold lengthening to change pitch. How cool is that? This is the larynx from the desert. I don't know if you've recognized that. Looks a little dry to me. When you stretch the vocal folds, the tension increases, and that is a primary factor in allowing the vocal fold, the pitch, or fundamental frequency to increase. The contour of the vocal fold is really quite important. Dr. Sataloff talked about this. When you have a normal modal phonation like I'm using now, the length of the vertical portion of the glottis might be around 3 millimeters or so. But when you increase the length of the vocal folds, they stretch. The volume is basically preserved, and so the thickness here will thin out. And so this, now in, say, in falsetto, that might only be 1 millimeter that is vibrating with the mucosa wave. For low notes, and for low notes especially with perhaps a vocalis contraction that bulges the fold, the vertical length of the glottis will increase. And this has a lot to say about the quality of the sound, close quotients, things like that. I still think that the string equation is still quite important relative to understanding the basic variables for phonation. The vocal folds are like a thick, not necessarily string, but a ribbon. The length here is corresponding to the tissue that's in vibration, and the T here, the tension, is the tension of the tissue in vibration, and then you have the density here. So as you increase the length of the vocal folds, the tension here is increasing faster than the length, so that the fundamental frequency will rise. Now, if you have edema, you might transfer this equation here into this expression here. This is nicely discussed in Ingotita's book. Here we have an external force. You might think of that as a cricothyroid from the outside. And here's where if you have this mass here, and if you have laryngitis and a lot of edema, this larger value here is going to drive this value here of the fundamental frequency down. In fact, I'm inclined to think that you can use these equations clinically for prediction before or after. Okay, registers, we talk a lot about registers. The basic ones are vocal fry, testomodal, and falsetto. They can be named different things, but we also have hidden registers, mixed registers, and everybody here has an opinion about those things, which is really, really cool. But sometimes we don't often see all of these, so let's take a look at what these three basic registers or regions look like. This is vocal fry. There's typically a fair amount of adduction. The vocal folds are really short. They're quite pliable, and so they have a low frequency. And quite often you can hear ticks. This is one reason why vocal fry might actually be used to strengthen adductor muscles. So there are closet fryers, I believe. Chest modal. This is showing a really nice mucosal wave. Closure from lower to the bottom. Then we have falsetto. Notice the mucosal wave is still there in this falsetto. Okay, so those are three basic registers, and then, but with talented training and all that, there's a balance between vocal fold length, vocal fold contour, adduction level, and subglottal pressure. All four have to be considered relative to how you deal with transitions and registration aspects. It's not just CT and TA for sure. Okay, adduction is a primary important variable. So the arytenoids sit on top of the cricoid cartilage. There's a short axis around which the arytenoids will rock, and there's a long axis along which the arytenoid will glide. So this rocking action is basically something like this, and the rocking action, if you want to contract the LCAs, lateral cricoarytenoids, to adduct, and the lateral TA actually as well. And so it looks like this, and good thing we have this ligament back here. Dr. Sataloff can tell you all about that. And then David Broad kind of measured this like 30-degree angle or so of that kind of rocking behavior. Then the gliding behavior is fairly straightforward as well on this facet. So when a person goes from breathing to phonation, both of these happen. There's also a little play in the joint as well, secondarily. So if you see the glottis open like this for breathing, the vocal folds are quite adducted, and the vocal processes are up and out. Now when you go to phonate, like this picture is showing, what happens? Well, you have the rocking motion down and in of the vocal process, but you have the gliding motion up and back a little bit, and that's almost like pulling the vocal processes straight across. And that's kind of like what it looks like from this picture to that picture. And that can be discussed more thoroughly by Dr. Sundberg. But that's why it looks like this comes across, even though you have those two major motions as well as some other play in the tones. Now there is actually a range of adduction within which you can phonate, out of which you can't. So if you're fully open here, this is not going to phonate, at least for the vocal folds here. Least resistance for breathing, actually. But there is a breathy boundary, and this is the breathy boundary for phonation. Then you have kind of a normal breathy boundary, then a pressed normal boundary, and then if you become aphonia with too much pressure, then you have gone outside what can be called the phonatory adductory range. So if you want to phonate, you've got to get into the phonatory adductory range. And this has clinical, surgical, and posturing relevance for sure. Yeah, so let's look at these qualities by looking at the larynx. Voice qualities will now be demonstrated. If I talk in a very breathy manner, such as this, you can notice that the space between the two vocal folds is slightly open toward the top of the slit. When this happens, air escapes and you get the breathy sound. If I press the larynx too firmly together like this, then the structures are pressed together and you get that pressed sound. And if I talk normally, they are not so pressed together. Sure. Well, let's talk about these air pressures, actually, subglottal, transglottal, interglottal air pressures, vocal fold movement, glottal airflow. So, Johann talked a lot about subglottal pressure, which is really, really cool. Basically, you inhale some air, you set the level-ish of the glottal adduction, you know, the quality that you want, like I just demonstrated. And then you apply the recoil, relaxation pressure, and torso muscle forces to reduce the volume of the lung. Bob also mentioned this too. So when will phonate happen? If the vocal folds are close enough and pliable enough, and the forces to reduce lung volume are high enough, then this creates enough subglottal pressure to force the vocal folds to move into oscillation. So the subglottal pressure will be greater if the vocal folds are closer to each other, or there's greater force to reduce lung volume. So those are important, actually, from a clinical and training point of view. Phonatory threshold pressure is the lowest subglottal pressure that causes and maintains phonation. It's around 3 or so centimeters of water for lower speaking pitches. This rate rises relative to pitch increase when the vocal folds, you know, have a little more tension to them. Also increases with adduction. And can vary widely across individuals. If you look at all the data, you wonder, okay, how'd they do that? And how'd they get those low pressures? So you have to be careful. And actually, it's from a clinical point of view, PTP will tend to be higher with lesions. So from the objective point of view in clinical measurement, you want to do PTP before and after. You can do it well. So you can document that improvement. The transglottal pressure, how is that defined? Measure the average pressure in the subglottis right here where it says C sub, a P sub, and measure the average pressure right above, P supra. The difference between those two pressures is the transglottal pressure. That's the definition. This pressure here minus that pressure there is the basic definition for transglottal pressure. So here's a note. I would suggest not using the term transglottal flow. Transglottal pressure is the difference between two places. if you take that definition of transglottal airflow would be the difference between the airflow, mean airflow here and there, but that's 0. So whenever, don't use that term if you wouldn't, please. Just use airflow through the glottis. That would be good. Airflow through the glottis. Now, interglottal pressures are the pressures on the surface here, well, the ones we're interested in are the pressures on the surface that push and pull the vocal folds. So let's kind of go into that. Here's the beginning of the cycle in the sense of air starting to come through. And then the vocal folds are separated, so you have a little air coming through. This is in a convergent shape, and that convergent shape is positive pressure because the flow is going egressively, and you get these positive pressures that push the vocal folds away from each other at the beginning of the cycle because the tracheal pressure is positive. That communicates into this convergent section. And then you reach the maximum opening, but you realize the flow is not maximum there because you have a vocal tract above it. And when you then go to the next stage here, when you start to have a slight divergence, that's when the airflow is maximum. And this divergent shape is just, narrower below, wider above. And so why the skewing to the right? What do we call skewing to the right? If you take the area of the glottis, projected area from above, that projected area is going to be over here in time, but the peak flow is to the right of that. And so that's why everybody has been saying skewed to the right of where the maximum glottal area would be. I think that's cute. And so it's due primarily to the inertance of the vocal tract, but there actually, the divergent shape is actually less resistant than the convergent shape with that same angle and diameter. And there could be this wall movement, when the folds are coming back, they're actually squishing the air a little bit. And that accounts for a little bit of that skew to the right aspect. But inertance, I would say, would be the main thing. So now it's divergent. Oh, look at this negative thing. Now we have Bernoulli effect coming into play. You want negative pressures that are pulling the vocal folds toward each other. And that's due to the Bernoulli effect. The Bernoulli effect is negative pressures relative to knowing what the Bernoulli equation is. And that actually occurs at the beginning of the glottis here because the divergent shape means that the area is increasing. But we also have, when the vocal folds are coming toward each other, it's shutting off the flow. So the molecules above the glottis are separating. When that happens, the air pressure is negative. This is called rarefaction. It's not rare at all, but it's a wonderful faction. And that negative pressure communicates into the glottis and helps to bring the folds together. There's also, if you have wide enough here, you might have separation of the flow and vortical structures in the glottis. That also might create negative pressures. So here's the deal. Here's the deal. That's so precocious. Here's the deal. So the vocal folds, when they're separating like that, you have positive pressures that push them apart. Out here, when they get maximally separated, you have the recoil, because they're like a mass on a spring. The push for the folds to come back is not interglottal pressure, it's the recoil force. In fact, the interglottal pressure is almost 0 at that point, because we're going from a positive to a negative. So it's positive pressure going out. Out here now it's the push from the recoil of the vocal fold being compressed laterally. And then as it gets back here, about halfway now, those negative pressures are going to start to kick in and help close the glottis because the recoil forces are less. So that's the word on the street. And then the folds continue to come back and they finally touch. And so notice that there's a glottal opening phase, glottal opening, ing phase, glottal closing, and a closed glottis phase for the glottis. All right, here's so adduction. What's adduction? This is the gross motion of the arytenoid cartilages that moves the vocal processes and the vocal folds toward each other before phonation begins, and moves the vocal processes and vocal folds away from each other to stop phonation. It is the arytenoids that are causing the adduction and abduction. It is not when the vocal folds are vibrating, this is not abduction, this is not adduction. It's the arytenoids that are considered articulators. We have the lips, we have the tongue, we have the velum, we have the jaw, we have the arytenoid cartilages. Why are they called, supposedly called, should be called in speech, articulators? Because they move together to do a job of moving the folds together for phonation and dephonation. So the arytenoids are a legitimate articulator in speech. So here is a modeling of symmetric. The two sides of the two vocal folds are the same. They start out with the same angles. And there are a lot of people in this room, actually, who have very sophisticated models, much more sophisticated than I'm showing you here. But you can see that the two sides are moving the same. The angles are the same. Here's the glottal flow line. The flow is the same from cycle to cycle. And the MFDRs are about the same. And so this is normal phonation. But if you have some asymmetry, we all have seen asymmetric motion where you get a little off relative. It's not completely in phase with each other. And that's what this is showing. This is where they started out at a slightly different angle, but it wasn't enough to make the glottal flow change from cycle to cycle. So this is actually where we've seen slight asymmetry of motion, but a normal sound from the voice. And here is my larynx. I want to show you what the glottal flow actually looks like. Here's my larynx, and here's an excised canine larynx. And they kind of line up. We have the arytenoid cartilages, posterior glottis, the right fold, left fold. The slit is the glottis. And, okay, so this has to make your day. So here, okay, first I have to maybe do that. Watch this. I mean, you can't beat this. This is seated airflow, and so you see these puffs of air that are shown in those glottal airflow cycles. And it's like the particle velocities along the entire slit, they all add together to give you that moment-by-moment volume velocity waveform that we show all the time, and that, you know, that's the inverse filtered flow. But this is what it actually looks like, and the acoustics are this changing airflow that's changing the densities locally. And then, every year I show this from the Luton Home Show. It's really kind of cool. Here's a little more complicated simulation where you have the vocal fold here. There would be one on the other side too, but shows the motion of convergent, divergent, and you have the particle velocities there. You get a little bit of change up here, but then you have down here high pressures, and then you have this vertical kind of structures that are simplistic in this case, but again, there are others in this room who have much more sophisticated models, and it's really, really cool. So, okay, we'll end with this. So here's a cough. So if you have a frog in your throat or something like that, and you have to cough, when you look at this, by the way, I hope 80% of you say, I'll never cough again. Because the constriction is so great, and the tissue is going to wiggle, 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 internally stressing and straining the tissue. So here's the closure. This is from Heather sharing her wonderful high-speed cough. So here's the cough and all the tissue, and there's the frog in the throat. But you see how all that internal stuff, so don't do that more than once in a lifetime. Okay, so we covered some basic tissue aspects, fundamental frequency, adduction, subglottal pressure, and other pressures. motion, glottal flow, and cough. Thank you very much.